So much for joining us today for our third session for this year, 2026, of the ACNS Women webinar. Today, we are very lucky to have some very distinguished speakers. Today's session will be chaired by Prof. Vladimir Beneš. Thank you for joining us. We have our eminent speaker from Japan. Thank you for joining us today, Prof. Kenji Ohata. And we have from Thailand, Dr. Titikan Wangapakul. And after this, at the end of the session, we will be introduced to our team of women neurosurgeons from Georgia. So without much ado, I will now call upon our first speaker, Prof. Kenji Ohata. Oh, and let me not forget before I go on, we have two discussants today with us, Prof. Mari Kusumi and Prof. Shigeaki Kobayashi, joining us to be our discussants. Thank you very much for everyone for joining us. And I think we can start off with our first speaker, Prof. Kenji Ohata. Would you like to share your slides?
Okay.
You can see it.
I'm ready to talk.
Okay, thank you, Prof. You can start.
May I start? Oh,
yes, you may.
Beneš.
Thank you.
Thank you, Professor Beneš, for chair my session. So nice to see you. So my topic today, what I select is surgery of cavernous sinus meningioma. I based on the 50 years history in the Department of Neurosurgery in Osaka Metropolitan University. Previously, this university was Osaka City University. 5 years back, we changed the name. So I am retired. I retired 5 years ago as a position of the chairman. I am now a specially appointed professor of Department of minimally invasive neurosurgery. So I now are selecting, of course, I don't like invasive neurosurgery, but some case, if the case is complicated, we must select the invasive neurosurgery, of course. So I'm a successor of Professor Hakuba. He is my mentor. And then Dr. Professor Goto is my successor. Now he is a chairman of the Department of Neurosurgery. And Dr. Morisako supporting Professor Goto. So, can you hear me? No problem?
Everything is fine, Prof.
Okay. So the topics is meningioma around and inside the cavernous sinus. There are so many meningioma, so many types, so many pathology arising in this area. And nowadays, endoscope is available. So many. This is a real center of the skull base. So there is a 360-degree approach available in this particular pathology. So this makes the young neurosurgeons so confusing. So this is the content of today's talk. First, anatomy of the cavernous sinus and history of cavernous sinus surgery treatment in the department. And I want to show the current strategy, and then finally I summarize my talk. So anatomy of cavernous sinus is very complicated. Of course, Lawton's group published so nice photos based on the cadaver dissection. This is a carotid artery, oculomotor nerve. This triangle is oculomotor triangle. Nowadays, people call this Hakuba triangle. And this is if you peel off the dura mater, cavernous sinus is exposed. There's so many cranial nerves and carotid artery. So this is a endoscopic view from inferior root carotid artery and it appear first. So this is our publication regarding the illustrated anatomy. This is very important for the surgical understanding. We must illustrate the anatomy of the cavernous sinus. This is book published 1996. This one published 2006. This is a cavernous sinus is actually not a sinus. This is a venous plexus. And it's located between two membranes. In this thick membrane is dura propria of the temporal lobe, and this membrane is periosteum. Cavernous sinus formed in these structures, and then cranial nerve located the lateral side of the cavernous sinus, and these are connected with inner reticular layer. This is a cavernous sinus from the cranial side. This is a plexus. It's continuous to the spinal cord. And if you peel off the dura propria of the temporal lobe, we can observe the cranial nerves, oculomotor nerve, carotid artery, fourth and fifth cranial nerve could be observed. This is a really important schema. And this is a cranial nerve. Each cranial nerve has its own dural perforation. This is the dural perforation of the oculomotor nerve, dural perforation of the trigeminal nerve. We call this one, of course, Meckel cave. I call this oculomotor cistern. We cut the dura along the cranial nerve. We can mobilize this cranial nerve. This is a very important surgical point. And this is a view, this oculomotor nerve. This is the Hakuba triangle. Nowadays, people call Hakuba triangle. And this is a anterolateral approach. So peeling off the dura mater could widen the surgical corridor to the central skull base. So in the orbitozygomatic approach, we peel off the dura propria of the temporal lobe to access the center of the skull base. Now, next, I want to show history of the cavernous sinus meningioma treatment in the department. This is a main publication from the department. We have so many publications. First publication was done by Professor Hakuba. It's 1982. And currently, of course, we continue to publish the data. So this is the first publication by Professor Hakuba in 1982. Surgical approach to the cavernous sinus, report of 19 cases. Already this moment, Hakuba present 3 possible routes to access to the cavernous sinus: anterolateral route, lateral route, and posterolateral route. This is his classification. And then 1982, he published a combined orbitozygomatic infratemporal, epidural, and subdural approach for region involving the entire cavernous sinus. I'm not in this publication because I was in the United States at that moment, this moment. This is a schematic drawing to show how to access inside the cavernous sinus. This is a Parkinson triangle, and this is a Hakuba triangle. This is a medial triangle. This is a very important schematic drawing to understand the anatomy of the cavernous sinus. There is a superior wall, lateral, posterior, medial, and inferior wall. This is a pentahedron cavity. This is a very important to understand how to access to this inside the cavernous sinus. So of course we developed the several procedure to access inside the cavernous sinus. We summarize this is in 2010 10, we summarize data regarding the role of radical microsurgical resection in the multimodality treatment for skull-based meningioma. So this time we analyze the outcome of cavernous sinus meningioma surgery. This is early period, mid period, late period. Early period is from 1985 to 1994. Early period outcome is not good. Patient develops loss of visual function, diplopia, and facial dysfunction like this. So we must change our strategy, and later outcome become good. So I want to show the memorable case, two case of memorable case. This is a primary cavernous sinus meningioma, 45-year female, presented with third to fourth nerve palsy. We perform orbital-zygomatic approach in this case. Of course, this moment, gamma knife is already available, but the patient has presenting diplopia, and we decided to operate this case to decompress the cavernous sinus. So this is a tumor staining. This is approach. We select the orbital-zygomatic combined AP and subdural approach. This is a peeling off of the lateral wall of the cavernous sinus by Professor Hakuba. I assisting this operation. So this is anterior petrosectomy. This is a combined orbital-zygomatic and anterior petrosectomy approach. During the operation, this is now we try to remove the tumor, keeping the cranial nerve intact. So this is we damage the trochlear nerve. So during the operation, some bleeding take place. Bleeding from the visual trunk of the carotid artery. So we try to stop the bleeding. It's continuous to bleed. Now bleeding. So we lacerate the internal carotid artery. Tentatively, we coagulate the meningohypophyseal trunk, but we very much afraid of occlusion of the internal carotid artery. So we now start the saphenous vein graft from external to internal carotid artery at midnight. We start this bypass at midnight, and finally we perform the bypass, and our final decision is radical resection of the tumor. We remove the tumor. We remove the tumor together with the oculomotor nerve and trachea and other cranial nerve, because there is no choice during this time of the surgery. This is a second optic nerve divided as well, and finally we remove the tumor totally. This operation starts from the morning and finish at morning, and this is outcome. However, of course, patient had a total thermoplasia on the right side, but no recurrence for the 30 years till now. Patient come to my outpatient clinic every year from Tokyo. Patient looks so happy. No recurrence at all. And this is a secondary case. This is a secondary cavernous sinus meningioma. 41-year female present with diplopia and cranial nerve palsy. This is a huge skull-based meningioma. We remove this tumor by transpetrous approach. I skip the operation because time is limited. And this is outcome. So we perform the radical resection. Most of the tumor is rejected. But next year, tumor start to regrow. We perform the radiosurgery and continue to grow. We perform the second radiosurgery after second operation. And finally, tumor continue to grow and patient pass away due to the tumor growth. So this is this is a secondary cavernous sinus meningioma. Finally, it's become the real cavernous sinus meningioma. And gamma knife, we are not sure gamma knife caused this malignant change or not. So now I want to show current strategy. So this is, there are several types of the cavernous sinus meningioma. This is a sphenoid-rich meningioma invading the cavernous sinus. Petrosal meningioma invading cavernous sinus. And this is a primary cavernous sinus meningioma. So many tumors, this is a primary cavernous sinus meningioma. Even in the secondary cavernous meningioma, we remove the outer side of the cavernous sinus. Extra cavernous portion is removed and the tumor left behind inside the cavernous sinus. It continues to grow, like act as a real cavernous sinus meningioma. So, even if we like invasive or minimally invasive surgery, we should know how to remove the tumor from the inside of the cavernous sinus with functional preservation of the cranial nerves. I show our technique. This is anatomy. This is a several approach, anterolateral approach, posterolateral approach, and inferior endonasal approach. So anterolateral approach, I show this is a sphenoid-rich meningioma secondary invading or anterior condylar process meningioma secondary invading to the cavernous sinus. This is a 66-year-old male with a visual defect. This is a tumor is mainly located outside, but the tumor invade to the inside the cavernous sinus. Due to the experiments of the last 30 years or 40 years, in this case, we leave the tumor outside of the cavernous sinus. This is a surgery by the oligozygomatic approach. This is the right side. This is the right, I change. This is the right side oligozygomatic approach. I peel off the lateral wall of the cavernous sinus. So I open the optic canal. So in this approach, we must identify each cranial nerve by exposing the cisternal segment or dural perforation. This is dural perforation of the optic nerve. And then this is a carotid artery. And we go posterior side. Posterior cranial process is removed. And then this is oculomotor nerve. Oculomotor nerve is exposed along its dural perforation. This is a basic technique. This is I call normal anatomy guided operation. This is a trochlear nerve. This is a dural perforation of trochlear nerve. This is a cistern here. We can safely expose the trochlear nerve along its own dural perforation. This is a final stage of the operation. This is a basic procedure to remove the cavernous sinus meningioma. I don't like to enter to the cavernous sinus because I don't like to injure the cranial nerve. This is outcome. This is a MRI 3 years post-operation. Patient KPS 90, so wonderful. And this is outcome. So usually I leave the tumor inside the cavernous sinus in this case. Now, next, I want to show the transpetrosal approach, posterolateral approach. I call this backdoor approach. Backdoor is very wide. If you carefully see this anatomy, this is actually Parkinson triangle. This is very wide. I call this backdoor. Backdoor is so wide. This is a big petroclival meningioma. This is so large. I don't know which is origin of the tumor. This is backdoor enter is so nice. We also published this mini anterior posterior transpetroral support to enter to the cavernous sinus. So this is a basic concept. This is a transpetrous approach on the left side. So in this, benefit of this approach is we can identify the root entry zone of the cranial nerve at the brainstem, and we find the cranial nerve and we follow the cranial nerve rejecting the tumor. So this is, I show the small case for easy understanding of this approach. This is a 44-year female presented with oculomotor nerve palsy. It's very similar to the case I showed the first case when where we injure the carotid artery. In this case, we select the transpetrosal approach because back door is so wide. This is a right-sided transpetrosal approach. Already bone is rejected. This is a mercury cave. Mercury cave is follows anteriorly to expose the trigeminal nerve. Now this is the trochlear nerve. We can also expose the trochlear nerve along the dural perforation. This is a mercury cave. This is a basic surgical technique is dissection along the normal anatomy. Now, final goal in this surgery is oculomotor nerve. So this is oculomotor nerve. Oculomotor nerve, I'm coming soon. Trochlear nerve is follows anteriorly. Now oculomotor nerve appears. This is usually anterior limit of this approach. Of course, we follow a bit to the anteriorly along the oculomotor nerve, but this length may be 5 to 7 millimeter. And then we remove this posterior part of the tumor. This is very safe approach. I will show the outcome later. This is of course, total resection is not goal in this case. Radical resection with cranial nerve preservation. This is outcome, tumor rejected. This is, this is outcome, patient oculomotor function, extraoculomotor function is completely preserved. I want to show the case. This is a case, the same one. This is another case, pre, post, pre and post, pre and post, pre and post, pre and post. And other one, pre and post, pre and post, pre and post. Of course, this anterior part, it is impossible to remove this part. I show how to remove this part later. This is a publication regarding the outcome of these 6 cases in 1918. So if you look at the post-operative cranial function, so no case has additional neurological deficits, usually completely preserved. This is a good, so some has a partial improvement of trochlear nerve, some is a recovery of the function. This is a so nice outcome. Of course, remaining tumor is gamma knife in some case. So I want to show the endonasal approach finally. This is a case, this is a very standard approach nowadays. This is a case of the huge cavernous sinus meningioma in the 13-8-year-old female with presented with a facial nerve numbness. So this case is firstly detected by transpetrous approach. Tumor left behind inside the cavernous sinus. This is a very young female, so no gamma knife yet, of course. We try to remove this part. So we published the endonasal approach with posterior crinoidectomy approach. This is wonderful approach. This is video. So in this case, in order to expose oculomotor nerve, we cut the intercrinoid ligament. This is also very important technique. And we can mobilize this, we can see the oculomotor nerve and fourth nerve, sixth nerve. So in the individual approach, exposure of the cranial nerve is very important. So this is a technique our colleague published in the World Neurosurgery. So this outcome, large one, transpetrous approach, endonasal approach. So radical resection is possible. This is an intercranial ligament ejected. Laterally, we cut the ligament. So this ligament is so important. Hakuba triangle so important regarding the ligament. So this is outcome of that case. Cranial oculomotor function is completely intact. It's surprising. So summary, this is conceptual understanding of cavernous sinus anatomy, and surgery is very important. You must understand the anatomy, and appropriate surgical doors should be selected to maximize tumor rejection with functional preservation. I like this Hakuba's illustration very well. And now currently we proposing the two line, oculomotor line and posterior cranial line. If the tumor located this anterolateral side, we select the anterolateral approach. The tumor located posterolateral side, we select the posterolateral approach. And then medially, we select the endonasal approach. So of course, gamma knife outcomes is so nice. This is reported by Professor Nanda group. So this is if we leave the patient only microsurgery alone, it's required. And adequate timing of radiosurgery is so important. Of course, I totally agree to this opinion. So we have many modulant technology, distinct element technology for surgery. We must know optical technology, radiosurgery, navigation system, information integration. We must all understanding this technology. So thank you very much for your listening attention.
Thank you very much, Professor Kenji Ohata. I will pass the floor to Professor Vladimir Beneš, chair of our webinar today, and also to invite our discussions later to give some comments. Professor Beneš, you can take over. Thank you.
Thank you. Thank you. Kenji, that was an excellent lecture coming from an excellent place. You know the names from Osaka, starting with Hakuba and followed by you and then Goto. It's always the key to knowledge and key to new understanding of things. With cavernous sinus meningiomas, I have a experience from very distant past. You would remember that in 1991 there was a world skull-base surgery, the first one organized by Majid in Hanover. Leaving that, I was ashamed that I'm not using all those approaches, transfacial and all the base, because everybody was showing extraordinary approaches, including cavernous sinus. This shame lasted for me until 1997 when there was the World Congress in Netherlands, in Amsterdam. And there was a roundtable on cavernous sinus meningiomas. And the panelists were big names, including Hakuba. There was Winkodol and Hakuba, Parkinson, Majid, and all these people. And at the end of the table, there was Gonziolka sitting. And all these big names were showing meningiomas resected from the cavernous sinus. And all these big names, they had double vision in quite a lot of patients, big percentage. And at the end, Gonziolka just said, well, we have this series. The tumors within cavernous sinus were controlled by radiosurgery, and the patient saw everything once only. So for me, this was the end of treating meningiomas within the cavernous sinus. Those purely within cavernous sinus, I always send to radiosurgery. I never offer them surgery. And doing surgeries for all the others, which are, let's say, outside the cavernous sinus, I always stop within the wall of the cavernous sinus and I leave the cavernous sinus portion for later radiosurgery. And I must tell you that I'm happy with this politics, not entering the cavernous sinus, but definitely someone should show us surgeries like you did. And I always somehow making up my mind whether not to enter or enter. But there was a really excellent lecture.
Yeah, it's a matter of discussion. Thank you very much, Professor. So it's a matter of discussion. We always wondering how to treat the small tumor inside the cavernous sinus. If the tumor
Always.
grow after gamma knife, we must remove some. So it's if we can predict the outcome, it's so easy for us for neurosurgeon. But
That's true.
yeah. So if the tumor is large, no wonder to remove the tumor from outside of the cavernous sinus as radical as possible. As I showed in some case, tumor left behind only inside the cavernous sinus. How we treat? If the patient is over 70 years old or 60 years old, we may leave. So, but the patient I show is 30 years old, 30 or 40 years old, very young. No, so I don't like to send the patient to the gamma knife unit. So this is so age is also a very important factor. So of course I know the effectiveness of gamma knife. I totally agree. After the advent of gamma knife, we neurosurgeon is very happy. Patients are happy, we happy, but some tumor don't like gamma knife.
I believe that you are following up all the patients on a yearly basis.
Yeah.
That you are seeing all the patients after surgery on yearly basis, yearly MR.
Of course. Japan has can possible to have a cross follow-up every 6 months, every year. We take the patient with MRI, and observation is first selection, of course.
There is also the question of tumor consistency. Do you have some idea how to predict it on MR?
This is a MRI prediction. I'm not specialized in the image analysis. Of course, we check the MIB1 labeling index. This is a very important information, but it's a part of the tumor, not the entire part of the tumor. So this is we also have a PET analysis. It's like a glioma, but not useful yet. Please let me know how to predict the outcome. And it's like a human being, good human becomes a bad human sometimes. Good benign tumor become bad malignant tumors. So it's a very complicated.
Once the meningioma is outside the arachnoid, really on the outside, it becomes more and more aggressive. You see them in a carotid cave, where the carotid is not covered by the arachnoid, then the tumor is invasive against the carotid wall. This is exactly the case what happens in
I agree.
Cavernous sinus.
Yeah, malignant one is malignant at the beginning of the treatment. It looks invasive already. So if the tumor is very invasive, so we must I want to know how to treat that tumor. I don't like to perform the bypass surgery. Some in the previously first say early stage we perform the bypass surgery to remove such a malignant tumor, but it's I guess meaningless.
Yeah, fully agree. Sharon, should we go on with discussion from the floor?
Yes, correct. Yeah, maybe Professor Kobayashi, do you have anything to ask? And also, yeah, then we have maybe you can ask first any questions or comments.
Unmute yourself. Unmute.
Okay, all right.
Thank you, Professor Ohata. Arigatou gozaimasu. I'm a neurosurgeon from Georgia, Sakartvelo. Thank you for a spectacular lecture. Beautifully complex cases with beautiful outcomes. I find it fascinating how so complex things can be presented in this understandable manner. So thank you very much once again for ACNS and all the panelists and hosts for this opportunity. I was wondering about the intraoperative electrophysiological monitoring. How much do you rely on it? Or do you solely rely on your anatomic experience and your navigation? And also, how much does the intraoperative monitoring correlates in the clinical outcomes in case of complications? Yeah.
So thank you for your question. This is a very important question. We have, of course, a monitoring system, but in some case, I trust my visual inspection most. So, even if the patient neural monitoring decrease, patient function recovers after the operation. So I have so many experience of such case. So anatomical preservation is most important, and anatomical preservation and vascular information preservation around the, we must leave the some pure matter, pure matter must be kept intact. This is a real microsurgical observation is very important. And so navigation system, of course, we use a navigation system. But finally, I love to have that's Tadabadai's question is most useful to run the skull-based technique.
Thank you very much.
Yeah.
Dr. Kobayashi, would you like to comment?
Oh, yeah, a little bit. It's such a great accomplishment you've done at the Osaka Metropolitan University. I'd like to congratulate you from the time of Professor Hakuba, who is a good friend of mine. I can tell you that Dr. Ohata has refined and very much after Dr. Hakuba's accomplishments to be very, very delicate surgery. And more than that, I think presentation is so good. I was succeeding Professor Sugita, and Dr. Sugita and me was talking about how Dr. Hakuba was presenting. His presentation was kind of difficult to understand. Of course, skull-based surgery is difficult to see, bleeding from all over, and sometimes you don't know where's the nerve and where the blood cell and so forth. But Dr. Ohata's time, I think we can understand more and more. And you can see how Dr. Hakuba was doing actually in your presentation. Also, Dr. Goto is now working in that direction very much, and we understand very well. Anyway, I think this skull-based surgery approaching to cavernous sinus, the basic concept in my mind is that how you can utilize the bone removal in order to approach the core point, the cavernous sinus. You can approach from anteriorly, you can approach laterally, temporally, you can approach from posteriorly. Now you're proposing from back door and inferior door and transsphenoidal approach. The question is, you can use endoscopic apparatus and surgery. One of my questions is, can you apply endoscopic approach in other route other than transsphenoidal approach? For instance, posteriorly, we may be able to use endoscopic apparatus and you anterior, laterally also. You are thinking of that. I'm sure you do. This is one question. And about monitoring, you said in your mind, visual confirmation is very important. I agree with you more than that. And in your mind, for people who are going to start their surgery of meningioma in the region of cavernous sinus, your suggestion is important in that how, in your mind, how weakness of the nerve, vulnerability. You see, in my mind, if you look at the difference between the seventh and eighth nerve, in my mind, eighth nerve is more weaker. And the oculomotor nerve is also weak and so forth. And you have lots of experience dealing with those cranial nerve. In your mind, visually and sort of feeling-wise, which nerve is the most weak after surgery?
Thank you for your question.
Give us your idea.
Yeah.
By grade.
So first question is regarding
question.
endoscope surgery.
Yeah.
So endoscope is nowadays available through the entire venue of for neurosurgeon. We have keyhole surgery, eyebrow and middle host approach, keyhole. So of course, it's possible to access to remove the tumor, but I always wondering what happen if the important artery is damaged. When I was live surgery session in Mumbai, some American neurosurgeon participate in the live surgery session using endoscope from Pittsburgh. I'm sure. So he damaged the carotid artery. So suddenly he closed we cannot see anymore. So I know Professor Hakuba also damaged the internal carotid artery. So we perform the bypass like I show you. If we use endoscope, I'm always wondering, is it possible to treat the bleeding or not? This is my potential fear regarding the endoscope. So appropriate approach, appropriate degree of resection, appropriate technique is so mandatory for the endoscopic surgery. This is the question to the first question. So second one, so cranial nerve, so weakness, so it is so difficult. So, optic nerve, of course, very big nerve. We must preserve it. And sometimes I can remove the pier of the optic nerve and to improve, and the patient has improvement in some case. And the third nerve so complicated because the patient, if complaint diplopia, regardless the degree of the palsy, and abducent nerve, Hakuba injures the abducent nerve and we suture it. Abducent nerve is monofunction. Its function recovers if we suture. Sometimes we perform the graft. And trochlear nerve is so tiny nerve, but if we injure the trochlear nerve, patient continue to complain the diplopia in the outpatient clinic. So for me, we must preserve the entire function of the extraoculomotor movement. This is my concept. So, but if the tumor is malignant, it's very invasive to the tumor. So, that is why I like to recommend the patient for the decompression surgery to the cranial nerve. So if we perform the decompression, cranial function improve. So most of the case, and then I observe, and finally I send the patient to the gamma knife. Of course, even gamma knife, some case, gamma knife improves the oculomotor function. I know this is also anyway, I don't like to access to the inside cavernous sinus through the cranial nerves. This is my philosophy to the cavernous sinus surgery. Thank you for your question.
Yes, regarding to that point, you are stressing the idea that the mechanical pressure or mechanical decompression is the most important in surgery in order to preserve nerve function. May I ask one little question regarding the visual function? You stress the idea of preserving vascularity to the nerve, to the region that you are dealing with. Take a look at the optic nerve. You see optic nerve, you see many vessels on the surface. And Dr. Hakuba is stressing the importance of venous system. But in my mind, looking at the optic nerve vessel, surface vessel, do you think that the vein, do you think those small, vessels are artery, vein artery? Just give us your idea.
So it looks like vein. I'm not sure, but in the tumor case is different from the aneurysm. Tumor continuously compress optic nerve, so collateral circulation developed. This is my impression. In that situation, if we remove the pia mater, which is impeded by meningioma, patient visual function improve. This is my impression. So tumor case, non-tumor case is different. This is I never hesitate to remove the tumor from the pia of the optic nerve. Even after, if we leave the tumor behind around the optic nerve, we finally perform the gamma knife. Gamma knife damages the optic nerve. So, mechanical injury is better than radiosurgical injection. So, this is my impression.
How do you think, Professor Beneš, what is your impression about the weakness of cranial nerves you're feeling?
Yeah. My former boss said, once you see the third nerve, you have a damage of the third nerve. This does not apply anymore. Now you should preserve them, and definitely the vasculature is the important or probably most important part. And in meningioma cases, you should consider in which cistern are you. Anterior clinoid meningioma is within the carotid cistern. So if you do not enter the chiasmatic cistern, you do not damage the optic nerve vasculature, and you do not damage the vision. And this is the concept which probably should be applied in all surgeries. And Kenji was talking about the oculomotor cistern. You were talking about the cavo mecheli, which is a cistern in a way also. So respecting the arachnoid respects the vessels and prevents damaging the structure.
I have another point to mention about what Professor Ohata stressed about, the importance of the cistern and the dural perforation point in order to dissect the tumor away from the normal tissues. I think that is very important, and with regard to the anatomy, I think it is important to learn. And as I am Roton's student, I think it's very important to learn anatomy. But recent times, I have read about Dr. Yashagi's anatomy. I think he stressed very, very strongly about the importance of preserving or going through cisterns. And I think I was very impressed by your comment about the importance of the cistern too.
Thank you.
One practical point, Kenji. What kind of monitoring do you use?
Monitoring to the which
Nerves,
huh?
long tracts. What kind of IOMs you are monitoring your patient during surgery?
Yeah, I'm monitoring, but sometimes I ignore the result. So monitoring, of course, is it's a medical legal problem we must use, and in some case we teach it teach us a very good information. Of course, if we touch the vascular structures, patient lost visual function during the operation, we must stop the operation. But it's brain tumor surgery is different from the aneurysm vascular case. This is my impression.
I think in the interest of time, maybe just one more any more comments, Prof. Kusumi? Do you want to comment anything before we go on to our next speaker?
Thank you. Thank you. I have one short question to Professor Ohata. I was very impressed by how well the bleeding was controlled near oculomotor nerve or some important nerves. Could you share any tips or technique points for hemostasis around nerves? Do you do every case for embolization of the IC feeding arteries?
Yes, so thank you for the question. When I was assisting the Professor Hakuba's operation, sometimes we coagulate the feeder together with abducent nerve, and heat injury was added to the abducent nerve. So this is nobody knows such kind of the phenomenon complication at that moment. So, and then we usually perform the preoperative embolization of the meningohypophyseal trunk usually. Otherwise, if the small artery, we can coagulate during the operation with a suction irrigation system, cooling the area by the water irrigation system. That's all.
Very nice.
So
Thank you.
embolization is so important in some particular case.
Well, sometimes it's very difficult to enter the hypophyseal trunk through the internal carotid artery, but your team is very nice.
So
Thank you.
yeah. Anyway, if the meningohypophyseal trunk is not occluded well, we must straight go to the meningohypophyseal trunk. So the case when we injure the carotid artery, we pull the meningohypophyseal trunk.
Okay.
We must coagulate, and don't pull, and coagulate and cut, and stop it. And we have a Doppler system monitoring. We have many monitoring systems. This is very useful, of course.
Yeah. Thank you. Thank you, Sharon.
Thank you very much. Yeah. Okay. Prof. Beneš, do you want to introduce our second speaker? Or would you like me to do it? Okay.
You will do it, please. Thank you. Sorry. I do not have the...
Professor Ohata, I think it was a very interesting topic, and I think a lot of questions, a lot of comments. I know maybe another opportunity again. So I'll go on to introduce the second speaker, Dr. Titikan Wangapakul. She's a consultant neurosurgeon from Yala, Thailand. And today she will be speaking on advanced neurosurgery in a rural area. Okay, Violet, you can take over.
Yeah, thank you for having me today. And well, should I share my screen here? Okay. Okay, can you see my screen?
No, we can't see your screen.
Well, let me.
Yeah, okay, we're starting to see it.
Okay, how about now? Okay, thank you. And it's a very wonderful and impressive lecture from Professor Ohata. And I learned a lot from that. And okay, and today I took a part of the women in the neurosurgery. I'll talk about actually my name is Titikan Wangapakul, and I'm from Yala, Thailand, the southern part of Thailand here. And I gained the board of neurosurgery from Ramathibodi Hospital, and I also take some fellowships in Tokyo and in the Little Rock. And I learned some endoscopic from Stanford. And right now, then after I finished my fellowship, I fly back to my hometown and then I started my work. This is my second year of work. So actually, I'm still young and new in this area of working. And today I'm gonna share what I did in the rural part of Thailand. It might be, I might not share a lot of my videos or my surgery procedure because I'm still young and I'm not doing that good, but I'm just showing some part of the world that we have the women in neurosurgery working. And let me start with my hospital here. My hospital named Yala Hospital, and it's a 600 beds hospital. We are a referral center from 3,000 provinces of Thailand. And people around here are Buddhism and Muslim culture here. A lot of people here are poor and undereducated. And there are also a lot of terrorism around this area. If you see Thailand has a Gulf and the southern part, there's a very beautiful ocean, beaches. And in the most southern part, next to Malaysia, we have 3,000 most provinces here. This is where I live. Sometimes we have a terrorism. Last month or 2 months ago, we are under the attack by the bomb in the gas station. And we still have a lot of problem of the illegal drugs around here. But people here are full of, they live with nature. They have a very beautiful mind and their lives are very simple. I like them. I mean, they are very nice people here. And this is how my patient lives. Some of them are poor and they don't have a lot of opportunity to go around or to go far to reach to the medical school or whatever, like quaternary center of Thailand. So they prefer to stay here and deny or refuse surgery, or some of them wait until the disease become advanced or maybe too advanced. And this is how my operating theater looks like. Well, we have a Leica microscope donated from Bangkok last 2 or 3 years ago, but now the screen is broken. We have an endoscope by donation also, but the lens are broken too. And navigation system is completely out of function here. We have neuromonitoring, but no technician. I still have to monitor by myself. I choose this one. It's from Japan. It's very good one, the Nihon Koden. We used to have an ultrasonic aspirator, but now it's out of function. And all the equipments I bought by my own. I have my own bipolar, I have my own scissors, because sometimes the hospital cannot provide it for me. This is the variety of our cases. We have all of the trauma, vascular, tumor, infection, congenital, and spines. Actually, I like to do tumor the best as my tumor, but in this area, sometimes I cannot choose that. I have to cure them in whatever they come. So I still have to do trauma. I still have to do vascular. I still have to do some spine surgery because the orthopedics, they doesn't do that. So this is the patients in my area. I will show you some. We have some gunshot, and we have some pedestrian injury, motorcycle accidents. Like this one was shot by their neighbor, and it goes to the occipital. I just do debridement, but the patient recovered well. I don't know, but he walked back home. The second one is the boy, 9-year-old boy. He fell from the bicycle with open wound at left ear. At that time, he was admitted to the local hospital for a day before referred to my hospital because of the alteration of conscious. The fracture involving the major sinus here. And also he has a brain protrusion from the side. So because of the transverse sigmoid junction involvement at that time, I did the craniotomy and removed all the fragment of the bones, and I dealt with the sinus that was extremely bleeding. I using the Leica clip to control the bleeding, and then I deal with the hydrocephalus. But in the end, patient recovered well. And he was handicapped a little bit. I mean, he cannot walk well, but now he's during his rehabilitation program. Sometimes we have a terrorism like this. There's a car bomb in the province next to my city, and the victim has the open spine fracture with the nerve root protrusion. He arrived my hospital at midnight, and because it was an open fracture with the nerve root protrusion, so I have to do the fusion at the midnight and finishes around 5 a.m. in the morning. It might be tough, but I have a good assistant. That's my scrub nurse. He helped me a lot in putting all these screws. And right now, I'm glad that my patient returned back to work in normal. We have some vascular cases. I think might be not an advanced, but like a kind of simple vascular, like aneurysm for everyone. And I also have to do it. The early problem is sometimes it comes in this big, like the one in the right side, and we don't have any endovascular team in our area. And the patient refused to go to another town. So mainly I have to do it by open clipping. All of the aneurysm here are ruptured. The patient will refuse surgery if it's not ruptured. So it's a little bit challenging. And it's also have a lot of drug-related aneurysm here. The next major cases in my hospital, we have a lot of infection coming with a poor hygiene of the patient around my country. Like in this case, then I learned to control them with the antibiotics sometimes, but in some patients, I cannot help them. Like in this 3-year-old girl with congenital hydrocephalus, come with the infected shunt, and I found out that in her brain, there's a lot of pus inside. I tried to give her medication as much as I can, and finally she passed. Sometimes we have a congenital lesion here. This is a term newborn. I was called one day in the summer, and the pediatrician asked me, shall we do the surgery or just let her pass? Because she thinks that this boy has an anencephaly. Look at his eyes and his brain. It's not in a normal shape. But then after that, I do the CT scan, and I think that he has a lot more brain than I expected. So I suggest them to do the surgery. And a year after that, he came back to my clinic. Now he's still doing good developmental progression, not a deficit. I just repaired the meningocele, the encephalocele in the back of at the back of his head. And then I think because of the weight that pulling his brain, his scalp, so it make that deformity, but actually his brain is still good. So that's why I decided to surgery in this case. But my majority is tumor. The tumor in my area, I have some skill of microscopic removal, and I do some endoscopic removal. This is my microscope. Actually, my endoscope here is the very old one, like 30 years ago, that my boss left it to me. And then I still use it sometime when my new endoscopic was out of function. You see, it's a little bit old, but it still functions well. What I have for my surgery is a drill, a bipolar, my scissor, my dissector, and knowledge. And I have my scrub, my best assistant. It's my nurse. I don't have any residents or intern or extern to help me. Due to the poverty, I think the most interesting of people in my area is they are poor, they are low education, so they live with fear. That's why I have this picture. You see that she came to me since she had the first one, the small one, and then she refused to do surgery. Even her eye was blind. Her right eye was blind, and then she still refused to do the surgery, and she came for the follow-up every 2 or 3 years until the last picture. That's when she's going to lose the left eye, so she decided to do surgery. I'll give some sample for the tumor in my area that I have to deal with it. This is 30 years old woman, come with the strength. She came with the strength. She complained that her husband noticed that her pupil on the right is wider than the left. And then she became headache and have some alteration of conscious. She referred to me intubated. And despite having the dexamethasone, she still declined. Her cognition is still declined. Her consciousness still declined. So I decided to do emergency surgery on that day. And it seemed to be a little bit bloody tumor. It's soft, but not much soft. And I cannot control the bleeding, and the temporal lobe was swelling. At that time, I removed the tumor and I tried to do fast, but still, I lost 6,000 millimeter cc of blood. But I still, I just can't secure the tumor, but not quite well. And the temporal lobe is swelling, so I have to close it as soon as I can. Well, I know that this is not a good picture for the post-operative, but at that time, it was a very, it was my very hard time to do the surgery alone with my scrub nurse. And when the brain is swelling, I was scared. But and my instrument is quite broken, so I cannot, but I just use it at my best. She came back to my clinic later and still return of function. Pupil go back to normal, can open both eyes. And I'll do the cranioplasty later. This is another example of the case that I'll show. 61 years old female. Previously in 2017, she diagnosed with the Cavernous sinus meningioma. We suggest her to go to the other provinces for the radiation, whatever she can, but she lost follow-up. Come back again with headache and alteration of conscious in 2024. Now I know that this tumor originates from the cavernous sinus. Now it's become the very big cavernous sinus meningioma. And I did the craniotomy approach with the transcavernous here, drilling some of the orbital rims and drill down the temporal base and try to remove the tumor. I think at this time, I was lucky that the patient was a little bit old, like 61 years old, so her brain is quite relaxed, better than the previous one. So I removed the tumor, but I still cannot remove one in the cavernous sinus. However, that's my first year of working, so now I was in the state of improving my learning curve. I'll try to get into the cavernous sinus now. So she came back to me later, preserving the third nerve function. I'm happy to see that. And yeah, she still survived now and doing well. Her pathology revealed the grade 2 cavernous sinus is a grade 2 meningioma. So I want her to go for some kind of radiation or gamma knife if possible, but she refused. I think she'll come back again, but I do the close follow-up, so I think she will come back again when tumor recurrence. But it will not be that difficult like the previous time that she's been lost for 7 years. Now she's getting better, and I will not lose her again. The other one, this is the 45 years old woman, come with left eye blindness, third nerve palsy, total ophthalmoplegia, and decreased sensation of the fifth nerve. She's been done craniotomy with tumor removal twice before I go back to my hometown. This is the film after the second surgery. For this patient, she lost she lost third nerve and she lost fifth nerve. So to me, it's quite, I mean, she gave me a little room for doing the removal, but the tumor was very stiff. So I did it 2 times to remove it from, to remove the first one at the temporal with peeling some from the orbital, the lateral orbital walls. And the second time I do one at the cavernous sinus, at the petrous bone. And finally, I lost a little bit of temporal lobe actually, but finally she come back and she has a good function, but her cranial nerve is still not recovered, I think, but no new cranial nerve deficit at this time. She's still doing well. But it's quite tough for me. I did it like from 9 to 20, 9 a.m. to 20 in the night, or maybe sometime 2 or 3 a.m. in the night alone for that bot surgery. But when the patient returned to me with a good result, I think it's quite, it's quite good. But still have a lot more tumor that the people in my area give me a kind of challenging time, because they always come when it's late or come with the alteration of conscious. They never, they are afraid of doing the surgery. So sometimes they refuse and come back again when it grows big enough for them to decide to do the surgery. I think what I learned from being a woman in this area is the neurosurgeon need a strong mind. I show you some case that I might be considered success for me, even it's not mean success to you, or even professor may say, oh, what a bad surgery, Violet. But let me show some more words. Like this case, 56 years old women with alteration of conscious again, never come in a good conscious. And she showed me a huge tumor compressing brainstem. But as I learned from the first case that I lost 6,000 blood, now I know that I have to go fast to remove it if it's soft. So this tumor is soft to me. I can remove it in 4 hours actually. But I didn't touch any vessel because the tumor is suckable, and also it can detach from the vessel very, easily. I think because it has the arachnoid protecting the vessel from the tumor. This is the real tumor in the arachnoid area. So I believe that I didn't touch any of the major vessel or even small vessel, but finally post-op it shows me like this. And I was like, I was depressed for 1 or 2 days. I was come back and thinking what happened. It shouldn't be like this. And I don't know how to say with her relatives, and also me, I expect her to be recovered, walk back home like other, but it's not what I think. But she still survived and begin to respond, I think because it was the right side. So this is what I think matter me the most, that when my surgery is not what I expected, but I have to cope. I have no choice. Go on and do it. This is another challenging 25 years old male with gait difficulty and alteration of conscious. And the MRI looks like this. I think it was a schwannoma at first. So I go by believing that there will be some arachnoid plane protecting the nerves, like I always did. There will be some arachnoid plane protecting the nerve and the brainstem. Sometimes I just follow the arachnoid and the cistern like other people did, but in this case, actually, it's not. It's a pilocytic astrocytoma. So when I realized that according to this anatomy, there's no border between the tumor and the brain tissue. So I realized that maybe I just get lost and I cannot differentiate it. So I decided to stop at the area that I think it cannot be differentiated from the brain tissue and the tumor. And the patient got the post-operative hydrocephalus. So I plan to put him a BP shunt. And this is the patient in my area. I told you, most of them has a poor hygiene, and I was thinking that where should I put the shunt without having an infection? But finally, I give him some medication before I put in the shunt and try to be as sterile as possible. But finally, he still developed the infection at the surgical site, right? Like this, there's a lot of pus inside. I think it connected to the ears and then making this worsening. And I do the reoperation 2 or 3 times to irrigate it and try to get rid of the pus as much as I can and start the antibiotic. Meropenem and vancomycin is enough for my patient here. And after that, he's getting better, but he still cannot ambulate well. So one of my interesting patient that made me learn that I should be more careful next time, and maybe I should think back what did I do wrong with this case and then try to improve. And the most tragic one for me is this 38 years old women with a persistent headache and become lethargy came to me in the very lethargic state. But I do, and I don't have any intervention team in my area, but I see a lot of vessel there's a lot of vessel around the tumor. And when I go inside, it was like hell, that many vessels are bleeding. It bleeds a lot, and I cannot control the bleeding. When I touch it, it bleeds, and I lost more than 10,000 milliliter of blood, and I cannot save her. Finally, the massive brain swelling happened and the coagulopathy happened. And then I know the additional that she was I know the additional clinical information from her relative that come later that she was a post-abortion woman. At that time, her hormone is still reaching the point that make the perforation of the vessel maybe. But I might can do something better. I lost her, but it made me weak it made my mind weak for several days before I give it up and start coming back to work. Being a woman, I think our minds sometimes are vulnerable. But as we started to become a neurosurgeon, we don't have any choice but go on with our careers and our patient. Well, I still do some endonasal surgery, but it's limited for me because I don't have any assistant. My ENT doctor, they do not do any endonasal thing. And so I can do just only simple pituitary tumor. Now I'm still doing some pituitary tumor, but I cannot, do the extension of it because I'm afraid of the bleeding. So I will choose to go by transcranial. But what I like is an endoscopic intraventricular surgery. Like this one referred to me from the other provinces, 81 years old with alteration of conscious, and she has a progressive drowsiness with the lesion at the septum pellucidum and the hydrocephalus. So they don't have the endoscope, but I have one. My endoscope, I bought it back from the US, so I have the flexible one. So I go and do the septum pellucidostomy and do the biopsy. Here I have the video because my endoscope can record, but my microscope cannot record. So I don't have any video to show you. I got the tumor and it finally reveals that the malignant lymphoma. She received a chemotherapy for a while before she passed because the lymphoma recurrent. Here is my equipment. I bought it by my own money. And it goes well. It still functions well. I also do this in the rural area. This is the 44 years old with alteration of conscious also. He has mass at both ventricle. So I do with the endoscopic. I use my flexible endoscope to go by transmagnetic approach and then do the biopsy. Because I have some feeling that this could be a lymphoma because it's just a periventricular area. So I did the biopsy and then wait a little bit. Yeah, it was an aggressive B-cell lymphoma, and he received chemotherapy after that and getting better for a while before recurrence. So I told you that in this area, I still have to do some spine surgery. I think spine surgery is the toughest thing for a woman, especially us who don't like, the hard work, don't want to be a carpenter. But still, we still have to do it. Might be once in 2 or 3 days. But the patient is there. If we not cure them, who will do? No one. So if we can help them, just do it. So I will conclude my speaking here, my session here with the neurosurgery in rural area. Why is this important? It can be tough because the patient or the people around the area in the rural area, they are poor. They don't have opportunity, or they don't have enough money to go to seek the better medical care in the other area, like in the medical school. So we can meet everything that we can. We can face with the difficult tumor. We can face with the aggressive aneurysm. We can see a lot of broken spine. So this is undeniable. If the tumor come in the small size, maybe I can give the money to go to the medical school. But when it comes big, we don't have any choice. We cannot deny, but we have to go on anyway. Even I have to lose 8,000 blood loss, I have to do it anyway. It's undeniable. And there are still a lot of patients who deserve to receive a chances to survive, as same as those in a big city. Like this girl, she came to me because she has a weakness in her legs and also a cramping pain for half a year. And she doesn't know what happened to her. And she seek a lot of medical attention around the area, and there's no result. And when she came to me, I did an MRI and found a cyst in the spine, in the conat medullaris, and I do the removal of the cyst, and then she become better, no pain, and she can work and go back to school. So that's why we still have to, there might be something we can help them in this area. It's better to move us to the rural area more than moving the patient to the bigger place, or a larger medical school or bigger hospital. There are still a lot of patients waiting for us around the world. I know that it's not only here or my area that need that help. I think there might be this kind of thing around the world that they still need help. And the last thing is about the women in neurosurgery. Worldwide, there are many women neurosurgeons who are fighting, exceeding the limits to help patients. And I would like to give my heart to all of them. And I know that it will be tough to work in the rural area or area that is limited. You will see all of the women in this picture, they are neurosurgeons working in this area. They still have to work to get up in the middle of the night and do operation, even in trauma, hemorrhage, or some tumor, like what I did. Now we have more neurosurgeons in our areas, and now I have to leave this place because of my family problems, but I still fly back to help them sometimes. And I feel very thankful, and I think I thank the ACNS that inviting me to speak all of this. I think my important key for the surgery in the rural area here is make it simple. My tool is suction, bipolar, and my sister. And it's really helped in area that we lack of the other things. The last of all, I want to thank my teacher, Dr. Nantaka. She taught me, and she was the first woman who working in this area for more than 30 years. Sometimes she's here alone, no one help and no other colleague. And now we are having more people, so she's still teaching us and back up us, all of us to work here. And again, I thank the ACNS again for inviting me to share a part of neurosurgery in the rural area from the southern part of Thailand. Thank you.
Yeah, thank you. That was really excellent, and that was really countermeasure to Professor Ohata's lecture. This is true neurosurgery, and this is was really very, very interesting. And I think that we should all thank you for showing us something which is probably more important, and Professor Ohata will forgive me, than some sophisticated treatment of very specific and very, in a way, rare disease. Anyone would like to comment on this?
Can I please, Dr. Violet, Kapun Krab, thank you very much for your work and for your truly heroic and commendable work you do, especially women that come from developing country, and it's very relatable talking about like how much you can do to help people with little resources you have. And I think your work is truly heroic, and thank you for sharing a job well done. I think you deserve all the accolades and praise. With so little, you have done so much. You help so many people, and despite the outcomes that might not be favorable in every case, you still try your best. So it's very honorable, and it's inspiring as a female coming from the developing country. Thank you very much, Juan.
In a way, Violet, I can tell you that I envy what you are doing.
Any other questions from the floor? Prof. Ohata or Prof. Kobayashi or Prof. Kusumi, would you like to?
If I may say something, I've been very impressed by your eagerness and effort and dedication. And my question, maybe many other people want to ask you, what is your driving force in your life as a neurosurgeon, just you have presented? What is the driving force? Religion or education, your family background, or your own spirit?
To be honest, I think maybe I was born in that rural area, so I see a lot of patients who needs to who lack of opportunity to receive something good, and I want to help them. Just that I want to help them, and I think the more I specialize or the more I'm getting better, the more or more complex I can help them. That's why I trying to. I spend a lot of money going to study around the world, just trying to improve myself, and now I'm on that steps. I think that maybe I can help them better. If I become better, so the patient will receive something better. I don't know if it answers you or not, but I just want to help them. And I want to help, and it might be challenging that I can help them the way other people cannot help them. That's why I'm trying to practice hard and learn hard, but now I'm not that good, but I'm on my way. I don't know what drives me. I just want to help them.
Thank you.
It feels good that you help people and you see them getting better. You see them having a better life, and that will reward you back that the way.
Oh,
That's it.
I have one question. Thank you for showing us a very tough cases. So you have a very widely variety cases. So it was very challenging for every neurosurgeon to manage all cases. So, but your training is skull-based surgery in Arkansas. So, in skull-based surgery fellowship is popular in Thailand. I heard many skull-based cadaver dissection course will be held in Thailand many times.
Yes, we have a lot of cadaver here, and I'm trying to develop the cadaveric program. I mean, we have a lot of cadaver now, and I went to Arkansas last 2 years, and I learned a lot from the cadaver there, learn anatomy. You know, before I went there, I know nothing about anatomy. If you're talking about some cranial nerve, I may be, oh, where it is. But after
Yeah,
that,
it's right.
I went there and I go to the lab every day, and I started to know the location or the anatomy around, and then I feel that it helped me a lot. So when I come back to Thailand, I know we have a lot of cadaver in our country, and it's very, I mean, easy to use, and it's quite cheap. So it was very accessible. So I try to establish a lot of cadaveric workshop in Thailand now, and trying to make it become cheap as I can, so people can come and learn. I trying to, I mean, enhance the cadaveric learning in Thailand right now.
Yeah, it's very nice situation. Yeah, you know very very well in skull-based surgery. So maybe your future is hopeful, I think. Thank you.
Thank you.
Right.
But I'm on my way. I mean, I still have a lot to learn, and now still I still sometimes I still cannot save the cranial nerve. But you see my cases, they all, I mean, all the cranial nerve function are not quite, I mean, some of them lost the cranial function, so it will be easier for me. But now I try to save what is not loose, or I try to save the normal function now. Is my next step is try to, I mean, save the normal function, or
Yes,
working
thank you.
on the patient with the normal function like that.
Violet, we are having this International Academy of Neurosurgical Anatomy, and we are organizing courses all over the world, and especially in underdeveloped areas. So whenever you would need some help or advice or whatever, feel free, check this academy, and we can be of service to you.
Oh, very thank you for that. I'm looking forward to. I think the most important thing for surgery is the knowledge of anatomy. When I go and I feel familiar to it, I think it might be, I mean, easier to deal with that.
That was what Yashar Gil was always saying: anatomy, anatomy, anatomy.
It is.
Is there any more comments? If there's no more, I think we shall go on to the next session. Thank you so much, Violet. I think sharing your personal journey is something that is very important for especially any young neurosurgeons that are in this webinar, because I think to show that you are able to overcome a lot of adverse, things around you is a good thing to influence the younger ones nowadays, because I think as we can see a lot, sometimes we tend to give up easily when you are just starting off in this. So thank you very much.
Thank you, Sharon. Thank you.
I can understand how you feel, because I was in the exact spot you were in 20 years ago, but things have changed. And I honestly tell you, the journey gets better. It is all worth it at the end. All right. So stay steadfast, and remember, everything you go through is actually a learning experience. It makes you not just a better surgeon, but a better person. All right.
Thank you. Thank you
Patient.
a lot.
You can do surgery till late at night because you're patient. Like Prof. Ohata showed us just now. I mean, he said, when he started off, they used to do surgeries overnight. And I believe from there, they slowly refined and they got better and better. So, take heed that, one day you will be, hopefully one day, there. All right. Okay. So I'd like, I'd like to now welcome Lika. Lika is from Georgia. She's got a whole entourage of neurosurgeons from Georgia. And I'd like to hand over to her to introduce herself, and so that we too get a bit of a taste of what life of a neurosurgeon in Georgia is. Okay, Lisa, thank you very much for joining us.
Hello, dear all. So my name is Dr. Leka Horvaladze. I am from Georgia, Sakartvelo, and I will be majorly just briefly telling you a little bit about my country and about the neurosurgery, what we are doing here. So the major point here is that the Georgia is a really little country because we are about like 4 million people overall in our country. So as you can understand, in some cases, it is like one part or one city of the big countries. So, but still we are having very interesting cases and variety of the cases in our part of the world. So we are still as a developing country, but try to implement as much new type of the neurosurgical fields as possible. And we majorly cover all parts of the neurosurgical spectrum. I also would like to introduce today my colleagues who are with me, Dr. Madonna Ahobadze. Also with us in the attendees, we have Dr. Khatia and Dr. Rusudan, who are also the part of our departments. We majorly work together for the pediatric neurosurgery team of Tbilisi Yashvili Children's Central Hospital. This is one of the major departments in our country for the pediatric neurosurgery, which covers all type of the diseases. What we have, this is implementing from the start, from the developing pathologies, malformations, until the trauma and the vascular diseases and the tumors as well. So major point is that we try to get knowledge as much as possible from the different webinars, also attending different countries, to bring back as much as possible for our country. So Dr. Madonna, me, and many of my colleagues try to attend different countries and bring all little stuff that our neurosurgery developed and get into the position what is now in the world. Of course, we are a little bit far from the Dr. Ohata, like what they are doing in their like university with the traffic like talk what he gave to us for us, but it's really a big achievement for us to take part in such discussions, because everything we can bring to our country and try to implement it in our everyday life too.
Thank you very much, Lika. Do you want to introduce yourself, Madonna? You're muted.
Greetings once again. Thank you, Dr. Liko, for such an opportunity. Thank you, ANS, all the hosts and all the panelists once again. I'm the youngest board-certified female neurosurgeon. It's my only third year of independent practice, so I don't have much to share, but I'm in the very beginning of my neurosurgical journey, but I also teach the future doctors. I have students with which I share experience gathered during such conferences, and also I take part in the ACNS European Association Neurosurgical Society course along with my other other colleagues, Dr. Hatia, we do the yearly training there and try to learn as much and teach as much as we can in the limited capacity. We are very familiar, and Dr. Violet's talk is very relatable because we're used to working with broken instruments, with broken microscope, with no monitor. So, like in different hospitals, we have different conditions. So I don't just work in pediatric, I also work in adult cases, and different hospitals in different cities have different opportunities and resources. So we're trying to do as much as we can with the limited resources we have, and your support and it's very very grateful for your support and your interest in our small country, and I hope we're going to follow the footsteps of the development of the neurosurgery in the area. Thank you very much.
Very much, Madonna. I think Katya is here. Do you want to say anything, Katya? Is she there or is she?
She's here, but she has a newborn baby. Maybe she cannot join because.
All right. So oh yeah.
Hadia is here.
Hi. Sorry for my baby's voice. I am thankful for your presentation. They were interesting for me. And Madonna already said our opportunities and Lika. And sorry, I have not normal time now.
Thank you very much, Katya. So it's so nice to have the Georgia Women in Neurosurgery joining us today. Thank you very much. I would also like to thank Prof. Kenji Ohata for giving us an excellent talk on surgery of the cavernous sinus meningiomas. I'd like to thank Violet for joining us. I'd like to thank you very much, Professor Beneš, for being our today for our chief, because Prof. Kato is not around. So thank you very much for stepping in. And I'd like to thank our discussants. Prof. Mari Kusumi, thank you for always being here. And Prof. Kobayashi, thank you for being around. Thank you, everyone. Prof. Beneš, would you like to say something before we close? Since Prof.
Definitely. Definitely. That was a great idea, such a webinar with underlining women in neurosurgery. And I was extremely glad to hear, Madonna, that finally the Georgians are attending the EANS courses, because I mean the training committee chairman and president of EANS, it was more than 15 years organizing the courses and never saw a single Georgian. So I'm now glad that you are getting involved. And as I see, you are also involved in ACNS, and you will be happy for your geographic location between the two major forces in neurosurgery. So enjoy and do a good job. And Sharon, you really did a great job. Thank you.
Thank you. Actually, basically, ACNS for us, we just like to reach out and go to places that no one goes to. You know, it's not just about countries that everyone sees. And I really enjoy this because I get to see everyone from different parts of the world. Like Violet, I mean, I've seen presentations from countries where women have presented things that are really amazing, and it's really great. So you give every one of us, you know, the extra courage and push to continue. And thank you very much. So thank you all for joining us today. Have a good Sunday, and hopefully we'll see you again. All right. So have a good week, and see you all again next month. Bye. Thank you. Good night.
Okay.